Hello, everyone. We're back again. Hardly time for a cup of tea or anything, really. But so we've got Dr. Nic Brayshaw, talking about integrating transgender health into mainstream general practice, which I'm really interested in this. I think I could do a lot better in this space. Before I introduce Nic, I just want to thank Besants Healthcare for sponsoring this session, and I remind everyone to pop into the sponsors lounge so you might be more likely to win a prize. There's a great pathway on transgender health and gender diversity on Pathway, so I remind you that it's always worth having a look at that because it's a great resource. So I'd like to now introduce Nic Brayshaw. He's a GP at Cardinia Health. He's a clinical lead of prevention at Westvic PHN. He's very interested in public health, and he's a great advocate for that amongst the GP community. His special interests include healthcare with people identifying as transgender and gender diverse, and he's founder and chair of the Geelong, I think that's Transgender Diversity Community of Practice. While enjoying the breadth of general practice, he's passionate about prevention and equity in health. And as I said, he's a great advocate in that space. So I'll hand you over to Nic to start his talk. Thank you, Nic.
Thank you, Anne, and hello, everyone. And thank you all for the opportunity to talk about integrating transgender healthcare into mainstream general practice. For the purpose of this talk, I'll use the abbreviations trans or TGD as being inclusive of all transgender, gender diverse, non-binary and other identities. I'll provide a broad overview of some of the issues, how GPs can help, including a brief overview of affirmative care, particularly hormone options, why it's so important. This is a generalist GP perspective. I hope to demonstrate to you the central role of GPs, which may often include coordinating various others' expertise, but actually much of the medical support required can be best done by you in general practice. Links to all the resources I mentioned, plus some more, are available for you to download. And later in the session, we'll interview a couple of special guests. So what do we mean by trans? A person whose experience of their own gender identity is incongruent with their body and incongruent with their assigned cultural gender identity. The ICD-11 carries a more detailed definition, but preparing this session, I've had front of mind GPs who may know of just a small number of trans patients in their practice. Some of you, though, I'm sure, probably see lots, and so I'd encourage you to please participate in the chat. And so too, anyone here today who brings lived experience. Statistically, in an audience this size, there should be several. Because how common is trans and gender diversity? Well, there's two large Australian and New Zealand studies here of surveys of secondary school students reporting around 1 or 2% identify as TGD. And European and American figures are similar. In recent years, there's been some high-profile celebrities like Caitlyn Jenner who've focused our attention. One thing for sure is that many transgender adolescents in modern Australia suffer exclusion, abuse, and consequently, high rates of mental health problems. Before I go any further, I'd like to acknowledge that I sit today on the traditional land of the Wathaurong people of the Kulin Nation and pay respects to their elders, past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander people here today. I also want to acknowledge that for many thousands of years in Australia, Indigenous cultures have been much more inclusive and respectful of gender diversity compared to the stigmatisation and exclusion of trans people post-European settlement. Gender diversity has existed throughout history. There's examples going back from Greco-Roman times. Trans people have always been here. Gender diversity exists across the globe and across many cultures. Trans people have place and culture and in fact ceremony in First Nations populations across the globe. So Gender diversity is not, a modern Western construct. Gender diversity really is part of humanity. There's abundant documentation that the mental health of many TGD individuals in Australia is impacted by high levels of stigma, social exclusion, family rejection, bullying and assaults. And for example, this recent Australian Trans Pathways study of the mental health of TGD young people found very high rates of depression, 75%, anxiety, self-harm, 80%, and 48% of these young people under the age of 24 had attempted suicide. It's well recognised that these poor mental health outcomes are not inherent to being trans, but they're due to the way people are treated by society, often experiencing discrimination, invalidation, and other adversity. Unfortunately, stigmatisation occurs within healthcare too. 60% reported having felt isolated from healthcare services. 40% had had adverse experiences within services, and 25% actively avoid healthcare out of fear of stigmatisation or invalidation. People may first present to GPs at any age across the lifespan. It's common for parents to seek advice about their children. Gender non-conformity is pretty common in early childhood. Best child psychologist advice is that children should be given the space to explore and role play, etc. And for the great majority, this is just exploration, and by about age of about 10 or so, they settle on their birth-assigned gender. But gender identity is usually pretty much locked in by about puberty age. And for some, puberty is a rude shock. To find their body changing in ways inconsistent with their own internal identity can be quite confronting and distressing. Commonly, people present later in adolescence. Many younger people don't have the insight or knowledge or family support to recognise or to articulate their identity until the penny drops. And they've very often endured quite a torrid teenage journey with refractory mental health problems in the meanwhile. Transitioning in their 30s, 40s, 50s may be complicated in other ways, sometimes involving a spouse who may or may not be supportive, and or consideration of their children's interests. And yet I know families who've successfully navigated all of this. And then you'll see people coming out in their 50s and 60s who may have endured a lifetime of trying to hide their true identity. Another big issue is that aged care services are rarely safe or inclusive. So what are the issues medically? Trans people face many issues, including, a big one obviously, is negative mental health impacts, suicide rates, apprehension about attending healthcare, and difficulty accessing affirmative care. What can I do as a GP? Well, begin by making sure that you're aware of a range of gender identities and diversity and common terminology. Ask patients how they identify and recognise their preferred name and pronouns. Look, this video is a good place to start. Some of you may have seen it, but I'll now wanting to play the first 90 seconds or so.
3, 2, 1.
When we think of the word gender, a whole lot of images rush to mind.
Most of us are taught the idea
that people are born a boy or a girl.
And we're expected to act a certain way based on what's between our legs. But that actually isn't true for everyone.
It totally ignores the huge and amazing world of people who are trans and gender diverse.
And that's what we're going to dive into in this series.
Being trans, gender identity, and what it's all about.
Welcome to Trans 101.
Traditionally, we tend to think of gender as decided by the body we're born in.
People are usually assigned female or male at birth.
But bodies and gender are actually pretty separate things.
Gender is basically part of someone's internal sense of self.
It can be male, female, neither, a mix of both, or exist totally outside of that. A person's relationship with their gender can also change over time as well.
The gender we're assigned at birth usually gets reinforced by the people around us over our lives.
Hearing things like, be a man, or you're such a girl.
It can feel like we're being told who we're supposed to be.
Most people feel comfortable.
Okay, so I understand there was an issue with the vision on the video, so apologies for that. That's just a short excerpt, but if you have time to do one thing, perhaps you might like to take 7 minutes tonight or later on to watch the rest of the video on YouTube. Now, let's talk about making sure that your practice is gender friendly. Providing a safe environment requires whole of practice buy-in. The reception desk is critical, patient's first point of contact. So ensure your staff are inclusive and respectful. This document's an excellent guide, best practices for frontline healthcare staff from Equinox Health Service in Melbourne. Ask and respect people's pronouns. Medical software packages vary in how well or poorly they handle that, but all practice software now allows a preferred name to be entered. Ensure staff refer to patients by their preferred name and create a welcoming and inclusive atmosphere. Other important things GPs can do include, most of all, I guess, providing support and information, linking people with peer supports and counselling, support and advocacy to help navigate the process or the system. Learn how to prescribe and monitor hormone therapy yourself. Refer appropriately, avoid pathologising. Understand minority stress due to external factors. And by that, I mean accept that family rejection is common. Unemployment and difficulty finding relationships are common for trans people. Even public ridicule and sexual violence and objectification are common. Understand that trans people transition because they feel they have to, despite the substantial price they pay in terms of such minority stresses. This is not a choice, this is an imperative. If you're interested to learn more, join the Australian Professional Association for Transgender Health, or at least check out the AusPath website, which carries links to these important guidelines. Now to mental health. Let's emphasise again that transgenderism is not a mental health condition, but gender dysphoria is a term that's been coined largely to reflect the common distress of not fitting societal stereotypes. And other mental health issues are common because of the way they're stigmatised. You can look up the DSM-5 criteria for diagnosing gender dysphoria, but essentially it's a clinical description of being unhappy with one's incongruous external gendered appearance, gendered social role, primary sexual characteristics. There's very rarely any diagnostic uncertainty. It's usually a history of indicators going back to early childhood. Gender dysphoria drives anxiety and depression, which not surprisingly are resistant to the usual psychological strategies or SSRIs, etc., but responds being able to transition, affirm one's gender. Social transitioning is often supported by hormonal and or surgical measures referred to as affirmative medical care. It'll be no surprise that many trans people have experienced significant trauma. Disordered eating rates of 23% often reflect bodily dissatisfaction. And trans people also reflect higher rates of neurodiversity, particularly ASD spectrum. The majority of trans people can benefit from engaging mental health support, given the adversity and the major adjustment they have to navigate, whether or not they have any diagnosed anxiety or depression. And most are very happy to access a GP mental health plan referral to a psychologist. Counselling with psychologists can help people to navigate social transitioning, coming out to family, negotiating workplace or educational issues, self-acceptance, and relationship issues, for example. And it can be very helpful to GPs to have a psychologist's opinion regarding a person's mental readiness to take on the challenge of transitioning, their understanding of outcomes, and their assess their competence to make such decisions. Changing name and gender on official documents or legal transitioning. The MBS is now gender neutral, and it's relatively simple to update Medicare, driver's license, passports. Gender change on birth certificates has been made a lot easier in Victoria by legislative reforms in the past year or so, and does now provide for recognition of non-binary gender identities. So as a generalisation, social transitioning is the most important and most challenging aspect for people to navigate. Many, but not all, may wish to back that up with affirmative medical options, which can align their body more closely with their authentic identity. This may be important to enable people to pass in daily life without being questioned or misgendered. It may also be important to support people's sense of esteem and self-image, and to be able to see themselves in a mirror without dysphoria and reminder of incongruence. Time today doesn't allow for a comprehensive sort of didactic on affirmative hormones. It's not a how-to, but there's more detailed coverage in the resources I've listed and in Health Pathways. Large longitudinal studies are still being gathered, but the available evidence suggests it's quite safe when appropriately medically supervised. And it's certainly much safer than denying people access to affirmative care. For many individuals, it's important to their mental health and may be life-preserving. Our practice nurses can vouch for the difference they've witnessed in some patients over the years coming in for their testosterone injections who were initially apprehensive, depressed, with minimal communication, and they're now confident young men who love to chat or share a joke with them. You can find this health pathway under specific populations tab, and then LGBTQI plus health. And when you scroll down, you'll find this general management section with branches into masculinizing or feminizing hormones, pediatric or older person considerations. There's several potential models of care for providing hormones, and under the age of 18, it usually involves shared care with the Royal Children's Hospital Gender Service. For adults, it's increasingly accepted for GPs to be initiating prescribing according to an informed consent model. Or some sort of shared care may be appropriate involving a prescribing GP, working with a private psychiatrist, psychologist, endocrinologist, or a tertiary service. Equinox in Melbourne have developed these informed consent guidelines, which have been endorsed by AusPath. And they place an emphasis very much on self-determination, patient-centred care, tailored mental health support. And so over several visits, you can confirm a history of gender incongruence, which is usually pretty clear, gather a comprehensive medical and family history, conduct a mental health assessment, and offer referrals for counselling or peer support, explore a person's ideas and concerns and expectations and goals, discuss expected changes from hormone use and timelines, discuss potential complications and side effects, conduct a basic examination, baseline bloods, offer referral for sperm cryopreservation prior to commencement of feminising hormones, and finally, assess and document a person's capacity for informed consent. In terms of available options for gender-affirming hormones, there's masculinizing hormones, essentially testosterone, feminizing hormones, essentially estrogen. There's testosterone blockers or anti-androgens. And the general target is usually to aim for normal physiological estrogen or testosterone levels relevant to their affirmed gender. Puberty blockers may be considered around the onset of puberty. And menstrual suppression is important for many people. So to speak about trans men, i.e. the birth-assigned females transitioning to a male affirmed gender, testosterone is essentially the only treatment that's needed. Injections are the mainstay for most. Reandron 1000 roughly every 3 months, aiming for trough levels 10 to 15 before doses. There are transdermal alternatives, but they're often less effective. GPs can initiate prescribing testosterone on private script, But for PBS authority prescriptions, referrals needed to an endocrinologist or sexual health physician. A couple of points of particular note here. Testosterone has multiple effects, typically taking several years to fully develop. Permanent effects include deepening of the voice and growth of facial and body hair. Potentially reversible effects include redistribution of fat away from the hips, increased muscle mass, and usually amenorrhea. An initial flare of acne is a common side effect. It's important to regularly monitor serum T levels, blood pressure, hematocrit, liver function, lipids. Other screening I'll touch on later. For trans women who were assigned male at birth, it's estrogen, and we usually use estradiol because of a better safety profile and because you can measure levels and aim for a serum estradiol between 250 to 650, i.e. that's the normal physiological female range. Transdermal estrogen is preferred, particularly for over 40s. It's safer from a clot risk perspective, and we know it's fairly low risk from postmenopausal HRT context. Oral estradiol valerate is a suitable alternative, preferred by some. Estradiol alone generally doesn't adequately suppress endogenous testosterone, so you'll likely need to add an anti-androgen like spironolactone or cyproterone. Again, the effects of hormones commence within a few months and may take several years to fully develop, and include change in body shape with redistribution of fat onto the hips, a reduced upper body strength, breast growth, shrinkage of testicles, and reduced erectile function. Estrogen side effects, I'll skip past because you're familiar with these. It's basically the same as the pill or menopausal HRT. Fertility counselling is really important prior to commencement of any hormones. Estrogen usually induces irreversible infertility, so consideration of sperm storage is really important. Testosterone also reduces fertility, but it's not reliable contraceptive, so storage of eggs can be offered. There's many potential surgical options people may choose. Removal of breast tissue for trans men, birth-assigned females, is one of the commonest. Full genital surgery with creation of a functioning phallus is complicated and expensive, but it is available in Australia. Options for trans women include labiaplasty with or without creation of a vaginal cavity. Cost, roughly speaking, $20,000 or so, but it also requires extensive post-op rehab and maintenance. There's various other potential surgical options, including things like lipotransfer, facial feminization, etc. But imagine for a moment if the need for some of these surgeries didn't arise in the first place. If the development of these incongruous secondary sex characteristics could have been prevented at the onset of puberty. If the young person could instead commence the appropriate puberty consistent with their identified gender. But these are enormous decisions to ask of an 11-year-old, but it is possible these days for puberty to be just put on hold for a few years until a person's mature enough to make their own fully informed decision after extensive assessment with all the supports in place, perhaps at the age of 16 or 18, and to then commence puberty with cross-sex gender-affirming hormones, or choose to simply allow resumption of their inherent biological puberty after all at a later date. So that's exactly what GnRH analogues can offer. Obviously, this is very much a specialist area, but Zoladex or Leukerin can be administered every 3 months. They're expensive, but they can be made available through specialist paediatric gender services. And they suppress that pubertal surge in pituitary gonadotrophins. But they can be ceased whenever, and puberty will resume, unless replaced by alternative sex hormones. As I say, this is clearly very much a specialist domain. Michelle Telfer's team at the Royal Children's have really led the world in terms of authoring these guidelines standards of care, which have been published in the MJA and have been subject of a very positive editorial review in The Lancet. This pathway describes the process of initial triage and assessment, followed by a process of extensive multidisciplinary assessments, throughout which a proportion of people choose non-medical pathways. It includes typically 4 sessions with a child psychiatrist or a clinical psychologist and paediatric medical assessment. Some may then choose to access stage 1 treatment of puberty blockers, which may be followed years later by stage 2 hormones. And years later, some, as adults, choose stage 3 surgical options. So in terms of outcomes, long-term data is still really being collected around the world. But this Dutch study followed 55 adolescents who went through this sort of process, and they found several years later that psychological functioning, life satisfaction, and happiness was comparable to same-age peers. Vocational and educational attainment was similar or better than the general population. That's a stark contrast to the outcomes for those unable to access affirmative care, which I showed earlier. Anecdotally, working with people working with trans patients, it's common to witness people who've been sidelined by dysphoria transform to happily engaged members of the community. Potential for regret is something many of us worry about, but this large series found regret was extremely rare. Close on 7,000 people and with a rate of well below 1%. And when regret did occur, it was more often related to external or social implications. Now, I'd like to welcome our first guest, Merryn Wake. Merryn, are you online there?
Hi. Yeah, I think I am. Can you hear me?
Good morning, Merryn. Welcome.
Good morning.
Thanks for joining us.
That's okay.
You're a mother of a trans child.
Yep.
And an experienced paediatric nurse. And your now 13-year-old son came out as trans a couple of years ago. Can you tell us about your reaction to that disclosure?
Yeah, thanks for having me. Yeah, when Jax came out, it was, I guess, created a bit of fear and thinking about what was to come, what the world would be like for him, as any parent kind of thinks about. And I guess also thinking about what do we need to do. My response was, I love you and what do you need? But in that moment, it was a fear of, he was also identifying that, you know, he was quite unwell, suicidal, mental illness. So yeah, that probably supported the fear in us when the disclosure was made.
Yeah, so your initial reaction was fear of what that might mean for your son's safety and welfare.
Yeah.
How did you respond to that, Merryn?
What we did was we started educating ourselves. Having worked in this space before this happened, I thought I knew a lot, but went into educating myself. What did it mean? What was our referral point? So who could we go to get support? Looking at, but also, I guess, listening to Jackson, what it meant for him, like what he was after and what he needed, and then thinking about how we do that. So surrounding ourselves with community was really important as well, listening to transgender diverse people and hearing what some of the options or where we could lead our family to.
Yeah, that family and social support is so critical for young people feeling vulnerable.
Yeah, absolutely.
What message would you like to convey to GPs today when they may be approached by a young person who's not experiencing a positive response from their family, or they may be too apprehensive to disclose to their parent?
Yeah, I think that mirroring language back to particularly young people. So you don't have to understand everything about the identity or the pronouns or the whatever they give you, but mirroring that language back creates that safety. I think it's really important too to look at referral processes, know what's out there, not just from a Royal Children's Hospital or gender service, but also peer supports, community supports, things like that. And particularly locally, particularly if they're in regional and rural areas, what is out there and how can you direct families to that?
Fabulous. And Merryn, can you tell this GP audience about your experiences of accessing medical support?
Yeah, we've been very honoured or privileged, I think, to go through the RCH Gender Clinic, and Jax is now on puberty blockers, which has changed, as you said before, Nick, a kid who was quite unwell to a kid that's thriving. And it's the service itself is incredible, wraps around our family in all sorts of ways, but also accessing peer support has probably been our biggest thing, particularly for us as parents, siblings, further family, is finding out people who are going through not the same but similar experiences has been absolutely profound in supporting the family and therefore us supporting Jax.
And Merrin, you had support also through your GP, I believe.
Yeah. So GP was fantastic. He said to me, I'm not really sure I get all this, but what do you need? And he's been fantastic with referring us to the RCH, but also in subsequent visits, understanding who Jax is, talking to him in non-gendered language, talking to him about his body as opposed to, and the function of his body opposed to a gendered kind of body, and that's really supported Jax to feel like he can go to the GP to talk to him if he needs to.
Great. And lastly, Merrin, you've taken on a huge role providing support for other parents in the Geelong region through Transcend. So could you tell us a little bit about that organisation?
Yeah, Transcend's a peer support network for families and carers of transgender, diverse and non-binary young people. And we are a group of parents pretty much and carers who, support each other. So that's an online presence as well as meetups and things like that. We also offer information, and we have local chapters, I guess, of Transcend. So we have one here, Geelong and Surf Coast, that we can support local families in getting referral points and knowledge.
Fantastic. Look, thank you so much, Merrin, and to your son, Jax, for sharing your experiences and insights with us.
That's okay. Thanks for having us.
Yeah. Here's a link to Transcend, providing that support for parents. Parents and family and schools often do struggle to know how to respond in the best interests of a young person. So there are some great resources available, and I've included links to some from Emerging Minds and from Transcend. This is a useful handout, I think, supporting trans and gender diverse children and their families, which I use quite a lot, written by a local Suzanne Prosser. There's a guide also for GPs and paediatricians. There's a guide for parents about supporting your transgender, diverse or non-binary child at school. A guide for schools, and a template for an affirmative, an individual affirmation plan. Now, to recap and highlight some key issues. Here's a very clear reminder regarding attempted suicide. 50% of transgender people, 15-fold higher than the general population. Suicide is a leading cause of death for Australians in the 15 to 44 age group, with tragically more than 3,000 Australians dying by suicide every year. How many of these suicide deaths represent trans or gender diverse people? We don't have statistics on that, but I think it's likely to be substantial. This slide highlights the powerful protective impact of parental support. So good mental health, 70% for those with supportive parents. That's in blue on the left, versus only 15% without parental support. Depression, 23 versus 75%. Homelessness, 0 versus 55%. Attempted suicide reduced from 57% to 4% with parental support. I don't have equivalent data around GP support, but I reckon it can also have a powerful benefit on mental health outcomes and reducing suicides. To hark back to that Trans Pathways report we mentioned earlier, it contains a number of quotes along these lines. My GP didn't understand, would intentionally misgender me in person and to family members. After legally changing names, I would still purposely put my old name on documents and referrals, even when told specifically not to, as Medicare wouldn't take them. They would be hesitant around hormonal medications and in some cases refuse to administer the medication to me. And I would have to go elsewhere or find somewhere willing to do so that I would receive the medication I needed. And remember those figures we saw earlier. 25% of people actively avoiding healthcare. So I want to challenge each of you now to ask yourselves, what other situations can you think of whereby young people with fulfilling lives ahead of them face such rates of morbidity, disability, and high mortality? And yet, a relatively simple medical support can make a world of difference. But the healthcare system's far from forthcoming or easy for them to access. How unjust does this reality feel? What could any of us do? What can each of us do in our practices to help address it? I think here's a real opportunity for prevention of self-harm and suicide. If we could all make access to medical care easier and safer for TGD identifying people, that would go a long way towards preventing adverse mental and physical health outcomes. Screening's really important. Ask all patients how they feel about their gender identity, particularly if experiencing mental health difficulties. Include this as a question in HEADS assessment. We've mentioned the importance of monitoring metabolic parameters. Smoking cessation is really important, particularly on estrogen. Encourage physical activity. In terms of sexual health, remember that a person's own internal gender identity has nothing to do with to whom they might be sexually attracted. In order to establish whether there's a need to consider contraception or PrEP, you need to ask. Cancer screening is determined by what organs are present. Screening mammography guidelines apply equally for anyone who has breast tissue, and cervical screening for anyone who has a cervix. In summary, the top priority when working with people of any age who identify as trans or gender diverse is usually around ensuring safety, number one, and adequate psychosocial support. Regarding affirmative medical care, for minors, it's usually best to refer to specialist services, RCH. However, wait lists are long and lots of support's required in the meanwhile. When it comes to affirmative medical care for adults, actually, GPs already have the necessary skill sets. You are accustomed to complexity and uncertainty in fluid labels. You are best placed to provide whole person care. And you have the skills, including hormone prescribing and mental health. You just need to extrapolate to different circumstances. Remember, this is a vulnerable population at risk of poor access to medical care. To offer nothing is harmful. The benefits outweigh potential harm. Hormone prescribing with monitoring is safe, and prescribed hormones are much safer than self-medicating. You can refer for hormones, but it's usually fairly straightforward. It's also about equity and accessibility. Everyone should have a regular GP. Trans people particularly need support before, during, and after any specialist involvement. Provision of affirmative care in general practice also normalises gender diversity. I'd like to close towards the end by saying that it's really inspiring to work with people who have the courage to be themselves, to advocate for their own healthcare needs, and to enlighten community attitudes. If you're interested in learning more, consider contacting Thorn Harbour Health, who offer training for GPs, as per this flyer, via 3 evening webinars. The Trans Hub is a fabulous, comprehensive Sydney-based website which carries lots of information for clinicians, for consumers, and for friends and family. In terms of peer support for trans-identifying people, Geelong has GASP for young people. In Ballarat, there's a new service recently set up by Your Community Health in conjunction with Thorn Harbour and the Austin. So feel free to contact this number. In Warrnambool, contact Brophy. In Geelong, Queerspace also have 2 local workers who provide a range of options, including groups, counselling, case support, and training, in conjunction with Drummond Street Family Services. Now, I'd like to welcome our next guest, and following this pre-recorded interview, we'll go straight to Q&A. Okay, so now I'd like to introduce Amiel Penny, who works with Wellways. Welcome, Amiel, and thank you for making some time available to talk with us today. Please, can you tell us a little bit about Wellways and what programs you offer in this space?
Yeah, no worries. Thanks, Nick, and hi, everybody. So Wellways is a mental health and disability support service. We've been around for a long time now.
Yeah, sure.
In Geelong, specifically talking about
Yes, so I understand we're having some technical issues with the video. We're just reloading. So hopefully that'll come through very shortly. Perhaps while we're waiting, I don't know if Anne can hear me. I'm happy to take, so if there's any questions while we're waiting for the video. Okay, so now I'd like to introduce Amiel Penny, who works with Wellways. Welcome, Amiel, and thank you for making some time available to talk with us today. Please, can you tell us a little bit about Wellways and what programs you offer in this space?
Yeah, no worries. Thanks, Nick, and hi, everybody. So Wellways is a mental health and disability support service. We've been around for a long time now. In Geelong, specifically talking about LGBTIQ services, we've got a couple of things available. One of those is specific NDIS supports, where we can match a NDIS participant with also an identifying worker. We take some time matching these participants with the workers, and it's really important. We've seen some wonderful, wonderful outcomes from that program. We've also got an LGBTIQ support group that is in the community mental health space, but we also invite NDIS participants to attend that. We sort of realised there wasn't enough LGBTIQ people in the village to refuse anyone's entry, so we're keeping that open to everyone over 18 years old. Very relaxed, not sort of a professional counsel sort of space or a psychology-led space. It's just a social group where people connect with their peers, and very much with mental health in mind. We've also got these community mental health programs and groups. We've got a program called Well Connected. This is one for people who do not have NDIS funding, and we are more than happy to support LGBTIQ participants. We have multiple trans identifying and non-binary identifying participants come through the program. I can do some direct work with them, and it's a wonderful program where they can access a peer worker for up to 12 months. And also access art groups, singing groups, and that LGBTIQ social group in there as well. Another really heavily populated with LGBTIQ people space in Wellways here in Geelong is the Youth Residential Rehabilitation Service. We've actually got 5 units with 10 beds where we can house LGBTIQ youths. We've also got a youth homeless outreach service, and we do some peer and community education as well. So that's just a little snippet of what we do here at Wellways.
Fabulous, Amiel. That's great. Thank you. And look, I think you also generously offered to share a little of your own lived experience.
Yeah, I think it's sort of important for me to mention that my journey through accessing hormones and my transgender journey here in Geelong has actually been really, really smooth, really quite easy. And I think it's important to highlight that because for me, it's been smooth and easy because I've got a voice. I'm literally trained to advocate, so I can advocate for myself. I'm quite confident in that space. I'd done a lot of research. I knew a lot of stuff, you know, when it was time for me to go and access hormones and speak to my GP. But it's become really, really apparent in the work that I do with my participants here at Wellways that not everyone has that voice, not everyone has that confidence or that experience. So I guess it's just, I really wanted to sort of highlight that thank you everyone who's been involved that I've come in contact with in Geelong. It's been a wonderful experience. But yeah, it's not always that easy for everyone, I guess.
So Amiel, if there's a message that you'd like to convey to the GPs participating today, what would you like to say?
Oh, so many things. I guess one of them, you know, first and foremost is actually thank you, and thank you for being here. It means so much for participants not to have to travel to Melbourne all the time or here, there and everywhere to access what should be, you know, really quite accessible services. I think one of the things I would really like to mention is that when you're seeing a patient, not all the time, but most of the time in my experience, these people have been thinking about transitioning or their gender diversity for years. You know, often I think us as trans people, we're made to feel like it's a trend or, you know, it's a phase or something like that. But for me, I've been thinking about it for about 20 years. So I think just really remembering to respect individuals and that there generally hasn't been a rush into this choice to actually come and see you and access services. And that, you know, being trans isn't always an easy feat. It's that people don't do it for the phase or the fun. It is fun, but it's not always fun, and it can be scary and daunting. So just be patient and yeah, keep doing what you're doing because it's wonderful and we need you doing it.
Thanks very much for that really important message. Finally, Amiel, Wellways is your day job. But you're also involved in a lot of other activities and particularly in peer groups in this space in Geelong. What's available at the moment for transgender diverse people in terms of peer groups?
Sadly, since isolation and COVID, things have dwindled a little bit, but we do still have some things available. You know, we've got GASP groups. We've got Queer Space in town now that provides some online stuff. We've got our Out social group. Geelong Rainbow is sort of tied a little bit with a meetup group. If you haven't heard of Meetup, give it a Google. There's an LGBTIQ group for adults through Meetup. And I always recommend people actually stay involved on socials. So follow Geelong Gender Group on social media, follow Geelong Rainbow Inc. on social media. Geelong Rainbow Inc. will often give a lot of information about anything LGBTIQ that's happening in the region so that people can get involved.
Fabulous. So that's great to know that there's a number of different options out there. So Amiel, I think that's all we have time for today. But look, thanks so much for participating and for that really valuable input.
Thank you.
Okay, so now I'd like to introduce.
Thank you, Nic. I think that's my cue to come on. Is that right?
Yes, that's fine. We can move now and to
yes. So we'll go a little bit over time, I think, but we won't have time to go through all the questions. But I just want to say thank you, Nic. That really was such an inspiring talk, and I almost feel like it has to be a compulsive viewing for the whole community. Actually, it's so many important messages, and the other thing it highlights for me is the expertise we have in our community and our medical practitioners and health practitioners. You know, we have such amazing expertise and it's just so great to see. So questions are over here. My screen's gone a bit funny. Yeah, there's just a lot of just great presentation, really inspired, great overview. This question is, this is probably a difficult one, what's the wait time for a Royal Children's Gender Service assessment?
At the moment, unfortunately, it's quite long. So approximately 12 months for initial intake. and up to 2 years for the assessment. So that's really blown out in the last several years. But I was very pleased to see in the state budget last week that there's been an allocation, significant allocation of more funding. So hopefully that will be deployed.
What would we do if we had a patient who was on the edge of puberty that, you know, really would benefit from puberty blockers? We can't really wait that long.
That's a very good question, and that is quite problematic at this point in time. I think certainly contact the Royal Children's and put the case to them. And if the person has not yet quite entered puberty or not quite reached two, then by all means advocate to the Royal Children's for them to be seen more quickly. Sometimes that's possible and sometimes it's not.
Again, that may be a place for GPs to be doing shared care in that space.
Look, certainly it's a very important scenario where people, young people, need support from a GP through this process. And because it's usually quite a long delay, and sometimes they're unable to access puberty blockers when they want to, and they need lots of support.
Okay. So again, wow, Nic, awesome, inspiring. Penny Scott asks, are there any particular psychologists in Geelong with specific interest in this area? Great talk.
There's quite a few psychologists in Geelong who are increasingly experienced in this area. I probably won't mention names today, but there are some who are members of the special interest group, and there are a broadening sort of awareness and understanding across many other psychologists.
People are asking YouTube. We will send you an email with all the links. Jane Opie asks, we need a longer session on this 2-hour symposium with a panel. Brilliant session, well done. I saw my first overt transgender early teens recently. All I did was say, I support you, but admitted no idea what to do, referred to a P. Another early step.
So I think it's important to offer that support and to engage with people. And I think it's important to be realistic about our own current knowledge. But I think offering to learn and read up about it. There's lots of resources I've provided today. It's not all that complicated, and a little bit of time reading would really help to bring GPs up to speed if they're not familiar with this area. I would also recommend, you can do a direct referral to the Royal Children's Hospital service, although there's a long wait before they'll be seen. I think linking people to peer support and to mental health support, if they're open to that, is really important. So GASP in Geelong is a social peer support group run through City of Greater Geelong, and can link people through supports for a young person. Headspace is often a good option.
Yeah, great. Lee Meakin's just saying, my children are a great source of education in this space. Anonymous, people in the community should learn from childhood to respect these people and not to hurt. Yeah, that's just a comment really about, community understanding of this issue. I think that's is lacking, isn't it? Jane Goddard saying, a friend of mine has tried to embrace her daughter who's informed her of preferred gender after finishing school, but now and then reminiscing will inadvertently call offspring their former name. I see her beating herself up about these little slips and trying so hard. I take my hat off to all parents dealing with these adjustments. I presume, Nic, that the new identity needs to be transferred back to the entire life. This must be minefield when looking at family pics, old photos, yearbooks. So that's just a really interesting story there, really. I totally understand the value of puberty blockers. If this is delayed well beyond typical puberty onset, are there issues with those teens at school? Waiting till 18 seems very late.
Yeah, so that's certainly a consideration and something which the Royal Children's Team are very much conscious of. And often the affirmative hormones might be commenced at an age of 16 or even 15 if the person's mature and competent to make those decisions. And so that puberty onset at the age of 16 certainly is less conspicuous.
Mm-hmm. 2 more questions and then we'll finish. Does a pathway to psychiatrist or psychologist in the initial stages reinforce the stigma that this is all in their head?
I think that has been, historically, that has certainly been a significant issue. I think, though, for the paediatric age group, I think it's very complex, and I think thorough mental health input is really important. But for adults, often that's not necessary or appropriate. And as GPs, we I think are fairly confident in conducting conducting mental health assessments or supporting people in mental health without necessarily having to involve a psychiatrist or anybody for an assessment. Psychologists often can play a really valuable role in support for people, if people are open to that, and most people are in that context. Yeah, and I don't think that that's stigmatising.
Final question, does the suppression of puberty cause them to grow more?
No, I don't believe so. There's not been really good validated studies around this, but what probably tends to happen is that the pubertal growth spurt may be delayed whilst on puberty blockers, and then they may grow when affirmative hormones are introduced.
Great. Well, thanks again, Nic. With great talk. There's a youth echo coming up, which these sorts of support and interesting cases will come up for discussion. So that's a great place to be talking this sort of thing. So I'm sure they'll do a session on this in the echoes. Okay, well, we'll see you very shortly, everyone. I think we've got 10 minutes rather than, because we're also interested, Nic. It was so good. And don't forget to fill in your evaluations. I think some people might be having trouble with that. We will actually email it to you in the next couple of days if you are having trouble, so don't stress. Okay, I'll see you soon. And thanks again, Nic.